Welcome back to the Deep Dive. Today we are tackling a condition that I think is a classic case of hidden complexity, pneumonia. It's an infection that seems so common, yet it can accelerate from just a simple cough to a really immediate life-threatening crisis.
It really can.
We've pulled together a dense stack of clinical sources, and our mission today is to, cut through the medical jargon, distill the core mechanics of this disease, and arm you with the kind of specific knowledge that truly makes you well-informed.
Exactly. I mean, when you look at the sheer breadth of what falls under the umbrella of pneumonia, from a mild, walking case to something requiring mechanical ventilation, it can be overwhelming.
Yeah.
So our goal is to quickly move beyond just the textbook definition and really identify the critical differentiating factors, the nuggets that determine severity and the best course of action.
Let's start at that fundamental level then. The sources give us a very clean, if maybe slightly dense definition. Pneumonia is the inflammation from an infection inside the lung parenchyma. So for you, the listener, what exactly is the parenchyma? And why is its inflammation so central to this whole problem?
That's a crucial distinction. The parenchyma is essentially the functional working tissue of the lung, the part where the air sacs, the alveoli, do their job of gas exchange.
So the business end of the lung.
The business end. And when that tissue gets inflamed, it immediately compromises the lower respiratory system's main function. Ventilation, respiration, and just, keeping the airways open.
So we have this critical lung tissue, and we have these infectious organisms trying to get in. What are the main entry points we need to worry about?
Our sources define 3 primary routes, and knowing these really helps link the condition to real-world risk factors. The most significant one is aspiration.
Aspiration.
This is where material like little food particles, stomach acid, or bacteria from your throat is accidentally inhaled into the lungs instead of being swallowed.
It's the body's safety mechanisms.
Yes.
Just feeling for a second.
Precisely. The second path is the one everyone knows. Inhalation of airborne droplets, from a cough or a sneeze nearby.
Right.
And the third, which is less common but can be very serious, is pathogens traveling through the bloodstream from an infection somewhere else in the body and then landing in the lungs.
Okay, let's unpack what happens the moment those organisms arrive. We're moving into the immediate pathophysiology here. The invasion starts in the alveoli.
Right. So once the organisms successfully colonize those air sacs, the immune system launches its defense. This starts an intense inflammatory response. And this reaction leads to vascular congestion, where blood flow swells the area, and edema, which is fluid leakage.
Yeah.
But the crucial consequence here is that the battle's byproducts, infectious debris, and exudate start filling up those air sacs.
The exudate being the technical term for the pus and fluid buildup.
Exactly. It's the fluid and cellular material that's leaked out during the inflammation. The lung tissue is literally filling up with the product of the immune response, which severely reduces the surface area for gas exchange.
So the body is fighting the infection by, in a way, clogging its own ventilation system.
That's a great way to put it.
And the structure of that clog, though, that dictates what clinicians see when they look at an image, right?
It does, and this is where the 4 structural patterns come in, which are really helpful for diagnosis. You have lobar pneumonia, which is that classic dense consolidation affecting an entire continuous area of a lung lobe, very clear on an X-ray.
Yeah.
Then there is bronchop pneumonia, which is more scattered and patchy, often localized around the bronchi.
And the other two, are they less common?
They are, and often trickier to spot. You have interstitial pneumonia, which affects the tissue between the air sacs, sort of the framework of the lung, making it sometimes settle on a standard X-ray.
Right.
And finally, miliary pneumonia, which appears as many small, discrete lesions spread across the lungs, often associated with a systemic disease like tuberculosis. These structural differences aren't just academic. They influence how severe the ventilation problem becomes.
That distinction, lobar being dense and visible, interstitial being subtler, that's a great piece of insight for you to have. Yeah. Now, moving from the structural pattern to the bug causing the issue, the sources all stress that where you catch this infection can dictate the entire fight.
This is the epidemiological context. We classify pneumonia by its acquisition setting. Community acquired, caught out in the world,
right.
Healthcare associated, caught in a hospital or clinic, which often involves more drug-resistant bacteria or opportunistic, which generally affects only highly immunocompromised individuals.
And that context is so important because it immediately narrows down the list of likely culprits and helps guide the initial choice of antibiotics.
Exactly.
Let's focus on the classic community acquired type, acute bacterial pneumonia, often from Streptococcus pneumonia or pneumococcus. This is sort of the drama queen of pneumonias.
It is, and up to 70% of us actually carry this bacteria harmlessly in our upper respiratory tract. It's just dormant until the conditions are right.
And when it strikes,
The presentation is acute and unmistakable. Sudden onset, shaking chills, a high spiking fever, sharp pleuritic chest pain, and a productive cough. The definitive, highly specific detail the sources give is the sputum itself. It's often described as rust-colored or purulent.
that rust color is essentially blood mixed with all that infectious debris, isn't it? It sounds so aggressive.
Yeah.
But the sources contrast that with the bronch-up pneumonia pattern. If the classic type is a sudden, high-intensity assault, what does the other one look like?
It's much more insidious, a slow, creeping onset. You might have just a low-grade fever, a nagging cough, and maybe only scattered crackles heard in the lungs. It doesn't have that immediate, widespread consolidation of a classic lobar case.
So less dramatic,
Mm.
but still dangerous.
Oh, absolutely. While many typical cases resolve well, we have to emphasize the severe complications. Pleuritis, which is inflammation of the lung lining, pleural effusion, fluid collecting around the lungs, and the most serious, a lung abscess or empyema, which is basically a collection of pus in that pleural space.
That escalation is terrifying. But shifting gears a little, let's talk about the type with the completely misleading name, Mycoplasma pneumonia, or what everyone just calls walking pneumonia.
Ah, yes. This one is fascinating because it behaves like a viral infection, even though the cause is bacterial. Instead of filling the air sacs with massive amounts of exudate, it causes patchy inflammation in the interstitial tissue, so the structural walls of the lung.
Which is why people don't feel as sick.
Exactly. Because it doesn't cause that dense consolidation, patients often feel well enough to walk around, which says it got its name.
So what are the symptoms of this walking type?
They're generally less severe but persistent. A dry, hacking, non-productive cough. It can just hang around for weeks, making you miserable. And importantly, it's highly contagious. It spreads very easily in crowded places like schools or dorms.
So if the severe bacterial type is defined by that rust-colored sputum and shaking chills, the walking type is defined by a persistent dry cough that you feel compelled to just push through.
That's a great summary.
Let's briefly cover the remaining causes.
Certainly. We have viral pneumonia, caused by common agents like influenza and adenovirus. Typically, this is milder and it presents with flu-like symptoms. However, it is a major danger for older adults and those with chronic health issues because it often sets the stage for a secondary bacterial infection.
Then there's a category that targets people who are already struggling.
That's opportunistic pneumonia, targeting individuals with severely compromised immune systems, for example, those with AIDS. The classic organism here is Pneumocystis jirovecii pneumonia.
And what's the key differentiator there?
It's abrupt onset leading to extreme respiratory distress, where the alveoli fill up with a very distinct, foamy, protein-rich fluid.
And finally, the worst-case scenario, aspiration pneumonia. We mentioned aspiration as an entry point, but when it's severe, like acerating stomach contents, why is that so much worse than just regular inhalation?
Because it's a dual attack that hits instantly. Aspiration of gastric contents is a severe chemical injury due to the stomach's low pH. This triggers an immediate, devastating inflammatory response and pulmonary edema, basically a chemical burn, before the bacteria even have a chance to proliferate.
Wow.
This can lead to rapid respiratory failure and, if untreated, very severe consequences like lung abscesses or even tissue necrosis.
That gastric aspiration scenario really underscores the vital importance of prevention and just knowing who is most at risk. So we look across all the sources. Who needs to be the most vigilant?
We can summarize the risk factors into two main categories for you: structural vulnerability and acquired vulnerability. Structurally, we look at the very young with immature immune systems and the very old with declining immune function and weakened reflexes. Acquired vulnerability covers those in debilitated conditions due to chronic cardiac or respiratory issues. And we also have to include major lifestyle factors. Frequent exposure to cigarette smoke, alcohol abuse, or drug abuse all significantly dampen the immune response and the lung's ability to clear foreign material.
Given that risk profile, the power of prevention has to be stressed. And that often comes down to one tool: the pneumococcal vaccine.
Absolutely. The pneumococcal vaccine offers a robust defense. While a single dose may offer lifetime immunity for many healthy individuals, the sources are very specific about who needs a booster. Critically, immunosuppressed individuals and all adults over 65 who were initially immunized more than 5 years ago should be revaccinated.
It's a simple intervention with a massive protective payoff.
It really is.
Let's pivot now to what the patient actually experiences. If someone presents to the hospital, what are the clinical manifestations the team is looking for?
Well, we categorize the symptoms into local effects and systemic effects. Local effects are centered on the lungs: cough, excessive mucus, dyspnea, which is severe shortness of breath.
Chest pain, and in serious cases, hemoptysis, which is coughing up blood. Systemic effects are the whole body symptoms: fever, a feeling of generalized weakness or malaise, diminished appetite, and potentially cyanosis from poor oxygenation.
The symptoms can seem relatively contained in the chest, but the sources warn of this life-threatening progression that can happen surprisingly fast. I mean, when you list off meningitis, endocarditis, and septic shock, it just underscores how quickly this localized lung infection can become a full-body crisis.
That escalation must be the main fear for clinicians.
It has to be.
It is. What happens is the infection can get so severe it enters the bloodstream. That's bacteremia. Once the bacteria are systemic, they can seed other tissues, leading to those severe secondary infections like meningitis, endocarditis, or peritonitis.
And the final stage.
The ultimate life-threatening progression is septicemia, a widespread blood infection, which leads to septic shock, and that dramatically increases the mortality risk. This rapid systemic spread is exactly why early intervention is completely non-negotiable. Given that severity, managing pneumonia requires a true interprofessional team effort. It goes way beyond just the physician writing prescriptions.
The care team is comprehensive. Naturally, it involves nurses, doctors, and respiratory therapists for breathing support. But critically, our sources highlight the role of speech-language pathologists, SLPs.
The SLPs.
Yes, who perform swallow tests to prevent that potentially fatal aspiration. And of course, you bring in specialized expertise from infectious disease doctors and pulmonologists.
Let's talk intervention. If someone presents with suspected pneumonia, what's in the diagnostic toolkit?
Diagnosis relies on a mix of imaging, lab work, and monitoring. The standard starting point is the chest X-ray, sometimes supplemented by a CT scan-computed tomography, if the X-ray isn't conclusive about the extent of the involvement.
And for lab work?
We need a sputum stain and culture to pinpoint the causative organism.
And the essential blood work, I assume that's key.
2 critical blood tests: a CBC, or complete blood count, which tells us if the white blood cells, the infection fighters, are elevated, and the ABG, arterial blood gas, which is a detailed look at how well the body is managing its oxygen and its acid-base balance.
Yeah.
We also track function in real time using pulse oximetry and, in difficult cases, may use a fiber optic bronchoscopy to visualize the airways or collect deep samples.
Once the organism is identified and the diagnosis is set, what are the pillars of the therapeutic strategy?
For bacterial infections, the foundation is pharmacologic therapy, targeted antibiotics. Alongside that, we use bronchodilators to open up constricted airways and improve ventilation.
Instead of the specific, overwhelming drug names, let's just focus on what those drugs do.
Right. They are essentially fast-acting and long-acting inhalers that help relax the smooth muscle around the bronchi. We also need agents to break up that thick mucus filling the alveoli mucolytics, like acetylcysteine or guaifenesin are used. But as simple as it sounds, often the most powerful and basic intervention is simply ensuring high sustained fluid intake to keep the mucus thin.
And when the patient is really struggling to breathe, medication isn't enough.
Then we move to oxygen and ventilation. Oxygen therapy is given to the patient who is breathing rapidly or is hypoxemic low on oxygen saturation using low-flow or high-flow systems.
And for the most severe cases?
For severe hypoxia and respiratory failure, intubation and mechanical ventilation become necessary to support the lungs directly.
What about the non-pharmacologic support, the foundational care that keeps everything moving?
This is the constant supportive care: airway management, lots of forced rest, and achieving that critical fluid intake goal. The sources recommend at least 2,500 to 3,000 milliliters of fluid per day.
Wow, that's a lot of fluid.
It is. We also use incentive spirometry to encourage patients to take deep breaths and inflate any collapsed air sacs.
Wait, I wanted to pause on chest physiotherapy. Is that still widely used, or is it mostly for the most severe cases? It sounds very hands-on.
It is still an important tool, particularly for patients who can't effectively cough up the secretions. It involves techniques like percussion rhythmically tapping the chest vibration and postural drainage, where you position the patient to allow gravity to help drain the secretions. It's labor-intensive but highly effective at physically clearing the lungs.
Now, we have to specifically highlight the unique risks for older adults. They're just profoundly vulnerable to rapid disease progression.
They are the most common group admitted to the ICU for this very reason. The risk is compounded by the natural aging process. Decreased function of the cilia that sweep debris, weakened gag and cough reflexes, a general decline in immune function, and of course, existing chronic conditions.
So their bodies are less able to mount an effective counterattack.
Exactly. The disease progresses quickly and can be far stealthier, meaning pneumonia and its complications are a primary reason for intensive care admission in this population.
Given the severity and speed, the level of vigilance required in hospital nursing care has to be extremely high.
Absolutely vital. Hospitalized patients need a pulmonary assessment conducted frequently, with a minimum of every 4 hours. Interventions focus on maintaining the airway, keeping the patient in a Fowler or high Fowler position to maximize lung expansion, promoting ambulation as soon as possible, and constantly pushing that high fluid intake, the critical 2.5 to 3 liter target.
And for pain management, I found this next detail fascinating because it addresses the most painful part of the experience, the cough itself.
That's right. The cough causes agonizing pleuritic pain, which can lead patients to suppress their cough, and that just makes the problem worse. Teaching the patient how to splint the chest pressing a pillow or their hands against their ribs during a cough makes the maneuver less painful and allows them to effectively clear their lungs.
Such a simple technique, but it must be fundamental to recovery.
It really is.
Finally, as a patient recovers and prepares for discharge, what are the crucial teaching points to make sure they stay well?
The 3 non-negotiables are: first, they must complete the entire medication regimen exactly as ordered, even if they feel better quickly. Second, maintaining that adequate fluid and nutritional intake is key to keeping mucus thin. And third, strict avoidance of smoking or secondhand smoke, and knowing exactly what clinical manifestations, like a recurring fever or worsening cough, to report to their provider.
And the success metric. How does the team know they've done their job?
The evaluation goals focus on normalization. Maintaining a normal temperature for 24 hours, having adequate rest, demonstrating a strong, effective cough, and, crucially, maintaining an oxygen saturation level greater than 90%.
So we've covered this huge spectrum, from the dramatic bacterial onslaught with that rust-colored sputum to the insidious walking pneumonia and how essential the context is. Where you catch it dictates the likely bug, and how it presents determines the urgency.
And we've seen that critical fluid goal of 2,500 to 3,000 milliliters per day is just as vital as the antibiotics themselves for recovery, acting as a kind of natural mucolytic. We've also noted that the disease can accelerate very quickly, often necessitating ICU admission if patients cannot manage their airways effectively.
Which brings us to our final provocative thought for you to mull over. We learned that patients who lack appropriate airway management are likely to be admitted, and that aspiration pneumonia is a massive risk, especially in older adults who struggle with swallowing. Given that aspirating gastric contents triggers that immediate, severe chemical lung injury before the bacterial infection truly sets in, the success of clinical intervention often hinges on the early, non-technical role of the speech-language pathologist identifying swallowing issues.
Right. If we consider the catastrophic damage of chemical aspiration and the fact that identifying swallowing issues or dysphagia is often done with a simple, non-invasive swallow test.
It raises the question, is a simple swallow test, performed universally and proactively, one of the single most powerful non-pharmacological preventative diagnostic tools we have in the fight against severe pneumonia? Something to think about as you realize that sometimes the simplest intervention can prevent the most complex crisis.